Society has a really significant obesity bias. A lot of times in our medical training, we aren't even necessarily taught about how to bring up weight in a way that is sensitive, in a way that is supportive.
Hello, everyone. My name is Dr. Nita Luanga. I have Dr. Sarah Stombaugh here with me. She's a physician that specializes in obesity medicine. She graciously agreed to be here on the show and to tell us a little bit about her specialty and tell us more about how we can improve our health. Dr. Stonbach, thank you for agreeing to be on the show. I was wondering if you could introduce yourself to our audience and tell them a little bit about how you decided to specialize in obesity medicine.
Yes, absolutely. Thank you for having me. I'm really excited to share with your audience. And I think this is such an important part of the medical field. And I love that there's been even more conversations in the field of medical weight loss over the last couple of years here. So, my background is in family medicine. I did my residency training in family medicine. And then, as I was practicing, realized over and over again, patients were coming to me asking for support with their weight, recognizing that it may have been the root cause or related to root causes of other health conditions. And I didn't really feel like I had the right tools in order to support them with that. And so I did additional studies and became board certified in obesity medicine and practiced that as part of my primary care practice for a while. And then when we moved cross country, so I've been practicing in the Chicagoland area. My husband is also a physician and was offered a job in Virginia. And I decided, you know what, this is really my opportunity to go all in to practice exclusively medical weight loss. And I decided to open a practice to focus on that for patients in the Charlottesville, Virginia area, and then throughout the states of Virginia and Illinois.
So, when should people consider getting the help of a physician that specializes in weight loss? Or when should people consider or think that they might have the so called diagnosis of obesity?
Yes, absolutely. I think the good thing is that when we look at weight, we look at overweight, we look at obesity, it is something that could be addressed by physicians in a variety of specialties, whether that is primary care, whether that is OB/GYN, whether that is pediatrics. There are so many people for whom it could be relevant and could be supportive. And so if you're concerned about your weight, I think it's worth asking. We do know there's really interesting studies that say that physicians don't always bring it up to their patients. Our society has a really significant obesity bias. A lot of times in our medical training, we aren't even necessarily taught about how to bring up weight in a way that is sensitive, in a way that is supportive. And so there's many patients who may know that they have a little bit of excess weight, but they're not sure if it's a problem. And so I would say if you're thinking about it and wondering about it, certainly ask. Hopefully your physician is happy to talk to you about it. And if not, you may be asking about additional resources like seeing an obesity medicine physician. To answer the second part of your question, looking at the diagnosis of obesity, there's a lot of different things that we can do to measure and define obesity. The most common definition is the body mass index or BMI, and it's a decent screening tool when we look at population studies, but when we look at an individual, it may not catch all the correct cases or it may inappropriately quantify people as having obesity where it's not really the case. And so a BMI of 18.5 to 24.9 is considered quote normal. From 25 to 29.9 is considered overweight, and then anything greater than 30 is considered obese. And so those are some decent screening criteria, although there's a lot more to that, and there's other definitions that we can consider as well.
Thank you for sharing that. And speaking of these so called definitions or numbers where we say somebody has obesity, are there situations where you would maybe question that diagnosis? Say somebody has a BMI of 32 and you look at them and you technically would not say they have too much fat tissue on them or they're not unhealthy, and vice versa. Are there situations where somebody has a technically normal BMI and you can look at them and say, this person is not very healthy. They have multiple conditions associated with obesity. I think we need to optimize their diet and maybe help them lose some of the excess fat tissue that they're carrying.
That's exactly it. Because when we look at the diagnosis of obesity based on BMI criteria, we're really failing to look at our body composition, our body fat percentage. So BMI is really just a calculation between our height and our weight. It doesn't take anything else into consideration. So it doesn't take your age, your gender, your body composition, anything like that. And so when we look at how should we more formally define obesity, it is based on things like body mass, body fat percentage, for example. And so, as you were alluding to, that's exactly right. I give the example of my husband all the time. For example, he is strong, he's a power lifter, does Olympic weightlifting, like that type of style. Not that he's been in the Olympics, he has not, but that type of style of Olympic weightlifting. And he's strong, right? He is a man who weighs a significant amount. His body mass index is 31. But if you look at him, you would never look at him and say, oh, that man has obesity. And he doesn't. If you look at him based on a body fat percentage, that would not be the case. The exact opposite is true as well, is that someone who lives in a quote normal sized body, if their body has a higher percentage of fat than what would be considered as normal, it's very possible then because they have more fat, that they have less lean muscle, that their body is not as strong, as we often see that metabolic consequences are more closely related to our body fat percentage compared to our weight alone. And so that body fat percentage piece is really important in defining and then supporting patients who may have obesity.
That is very interesting that you talk about that, the BMI is not the whole story. And we also need to look at the individual as a whole. I think the UK, and I'm not sure if other European countries have taken this or applied this, but they have an ethnicity adjusted BMI. I think I noticed a trend where people who are from developing countries who live in the UK, I think people from certain African countries, sub-Saharan Africa, I think Asia, they adjusted the BMI down so that I think around 27 is adjusted up to 30, and that's considered obese. And then I think people from perhaps the Middle East, North America maintain the same BMI. And then I think same with the Caribbean. The Caribbean is also on the so-called universal BMI that we use in North America. But my question was like, okay, a lot of people from the Caribbean are of African descent. Why didn't they necessarily adjust their BMI down the same as they would for people from the African subcontinent? It's a bit hard to say. I suspect they use population studies. But what do you think about adjusting BMI perhaps for ethnicity? Do you think we should do it? Do you think we should apply it in North America? Or do you think this is very useless and we should do something different?
Yes, I think that's an excellent question. And I wish I had a great answer for you about the African population and why in the Caribbean it wouldn't be adjusted, but then in another population it would. So I'm not sure about that. I do know that for Asian populations, that has been validated that Asian populations tend to, at a lower body weight, have a higher fat percentage that can be associated with metabolic effects. And so we do need to make sure that we are screening and diagnosing and treating people, and that potentially we're intervening earlier. And so we look at BMI criteria of 23 or 23 and a half. I'm blanking on the exact numbers as the threshold for overweight, and then about 27 for the threshold of obesity. With those numbers, are we able to support someone in whether it is reducing their weight or supporting them through that, so we're not waiting until things have gotten out of control? Let's make sure that we're intervening at the time where it really makes sense and is clinically relevant for the patient.
I think something that you mentioned, metabolic consequences of obesity, I think that's a very interesting topic for those individuals who are watching us who are not in the medical field, and even for our medical colleagues who don't necessarily have much of a background in obesity medicine. What are some of the consequences, metabolic and or otherwise, of having a high BMI?
Yes, absolutely. So it's interesting because it's really related to our body fat percentage. So when we look at body fat, and then particularly body fat that is carried in our essential part of our body, in our abdomen, body fat in that area is more closely correlated to metabolic consequences, things like heart disease, things like high blood pressure, things like elevated cholesterol, things like insulin resistance. So conditions like prediabetes, diabetes, polycystic ovarian syndrome. And so these type of conditions and others are more correlated with having central adiposity or carrying weight around our midsection. And so body fat in general, but then especially when it's carried around our middle, is more correlated to some of these other health outcomes.
Very interesting. Very interesting. Are there any other medical conditions that tend to occur in individuals that have more fat tissue or higher body fat percentage?
Yes, absolutely. So, in addition to some of the things we just named, cancer is very common. So, we know that
Mm.
there are certain cancers that are correlated with obesity, particularly colon cancer, breast cancer can be correlated with obesity. Other conditions that we wouldn't necessarily even tie together, like depression, for example, and mental health conditions, are very commonly correlated. Then we look at orthopedic conditions, not necessarily correlated specifically to body fat, but just to weight in general,
Mm.
especially arthritis of the knees, arthritis of the hips. These are weight bearing joints, even our ankles. We can see arthritis developing in those more significantly in patients who have obesity.
Very interesting. So if somebody's not in the medical field and they feel like they might be overweight or they might have a higher body fat percentage than they would like to have. When should they consider seeking the help of a doctor that specializes in weight loss medicine, bariatric medicine, or obesity medicine?
Yes, absolutely. So, one of the things I would recommend is to start with your primary care provider and have a conversation with them. Am I at a healthy weight? Another thing we can do is look at our abdominal circumference, look at our waist circumference to see is there anything that's concerning there. So, we talked about body mass index as a screening tool. And while body mass index can provide some useful information, it doesn't tell us anything about that body fat percentage, for example. So if you were to measure your waist circumference and get an idea of is it elevated, a waist circumference compared to our height should be less than half. And so if you measure your weight versus, or your waist circumference rather, versus your height, we want to see that percentage is less than half of it. And so that can give us an idea, okay, even if your doctor hasn't mentioned anything to you, okay, is there something going on that I should be thinking about, that I should be asking about? One of the really neat things is that over the last couple of years, there's been a lot more conversations about medical weight loss, about supporting patients with losing weight. Some of the old advice of eat less and move more, we definitely still hear that in medicine, but it's becoming less and less. And so I would recommend for someone to ask their doctor, hey, are you concerned about my weight? Are there any consequences that are related to my health otherwise? Are there things that I should be doing to address my weight? And you may be surprised to find that your primary care physician is an amazing resource for you. Now, hopefully, if they're not, if it's not something that they're really well studied in, that they will recommend for you to see someone who is certified in that. And you can certainly look for people who have been certified. Now, it's interesting, the American Board of Obesity Medicine also does certify physicians in Canada. And so that's a great resource. You can go to the ABOM, the American Board of Obesity Medicine. And even for patients, there's a provider finder and you can search in your area and see are there physicians who have been trained in this area, done additional studies in this area, because we know that it's really multifactorial. It's not just what we eat, it's not just our movement, it's not just our genetics or our other medical conditions or medications or stress or sleep, all of these things put together. And so you really want someone who's going to help you with that comprehensive support.
Absolutely. And I like how you mentioned that besides looking at BMI, we can look at somebody's waist circumference to their height. Are there any other ways that we can determine if somebody has a high body fat percentage besides, say, using the calculation of BMI, which we talked about why it's faulty, and or waist circumference?
Yeah, so really one of the best ways is to do a body composition analysis. Now, there are machines that can do this. Commonly, you'll find them in physicians' offices, especially weight loss clinics, or even in gyms, very commonly will have these as well. Sometimes their accuracy can be dependent. So, a lot of the scales where you'll hold electrodes with your hands and you'll stand on electrodes in your feet, and they do a bioimpedance. So, it sends a current throughout your body and it's measuring the resistance between water and how that's absorbed basically in fat versus how that's absorbed in muscle mass and other tissues. And so we're able to give a pretty decent estimation typically with those type of scales. There's also DEXA scans that are looking more formally. We think of those a lot of times for bone density, but they can also assess the body composition. Those are a little bit more clinical and done in a formal setting, but that is an accurate way to assess as well.
Okay, very interesting. So I want to move on to a slightly different topic, but still related. So, in terms of when a patient comes to you and they're looking for advice to help them manage their weight and reduce their body fat specifically, because we do know that when people are losing weight, they can lose muscle, and that's not necessarily something that we want them to do. We want people to maintain their muscle mass. But what would be one of the places you'd start or recommendations you start with when advising people to help reduce their body fat percentage?
Yes, absolutely. So, in our initial visit, we do a really comprehensive intake because we want to understand their other medical conditions. We want to understand what foods a person might be eating right now, what their movement looks like, what their sleep schedule looks like, if there's any concern for underlying sleep conditions like sleep apnea, for example, or other conditions that are affecting the quality of sleep. We take a look at stressors in life and how are we eating in response to things beyond hunger. Many of us eat for hunger, many of us eat for many reasons beyond hunger. So understanding what that looks like, understanding a little bit about your day-to-day life. Are you someone who is running all over the place, you've got one, two, three jobs, you've got a family that you're taking care of, these factors really make a big difference. And so it's important for us to understand them. Paying attention to things too, are there other medical conditions that a person has or medications that they're taking that are impacting their weight in a negative way? Are there other weight loss attempts that they've done in the past, things that have worked really well for them, things that have not really worked well for them? Have they done medications before? Have they had bariatric surgery or other procedures before to support their weight? And is there any history of eating disorder? A lot of patients who struggle with their weight may have had either in the past or even actively now history of eating disorder. Commonly, we see things like binge eating disorder, but even histories of things like anorexia, for example, is fairly common in the patient population that I work with. And so making sure that we're understanding all of these things so that as we're moving forward, we're giving really appropriate advice. If someone has a history of eating disorder, we really want to be mindful that we're not going to trigger those type of behaviors again. That our message for everyone is really about reconnecting with one's body, thinking about how your body is feeling in terms of hunger, how your body is feeling in terms of satiety, how you can pair certain foods to create that. So thinking about protein, thinking about fiber, thinking about the types of things that help your body to feel satiated and feel fueled for hours later, thinking about movement that we love. And so this happens slowly over time where we meet someone where they're at and then start to just nudge them in the direction of their goals. And that may look like just lifestyle intervention, things like nutrition, things like movement, things like sleep modification, stress management. And it also may look like medications to support their weight loss journey as well.
So, speaking of ways to support our patients, in addition to lifestyle modifications, looking at the way they're exercising, they're moving, looking at their diet, making sure they're sleeping enough. There's the obvious, and I think probably what our patients or our audience will be most interested in, weight loss medications. What are your thoughts on weight loss medications?
Yeah, so I'm really glad you asked because it is a conversation that is all over the media, all over social media. Everybody is talking about Ozempic, Wegovy, Zepbound, Manjaro, all of the GLPs especially. And they're really phenomenal medications that can be a great tool in the toolbox in order to support our patients. I think one of the things that's really interesting is that it's opened the door for people to start asking the question and wondering, okay, is this something that might be a good fit for me? So we do have some of the newer medications, the GLPs that I just mentioned, but there's actually older medications as well that can be really supportive, especially when we think about the reasons by which someone is struggling with their weight. Sometimes a person's struggling with really significant food cravings, and we can use medications that target that. Other times, someone is struggling with over hungry or feeling like they are just hungry and no amount of food will satiate them. We can look at different medications for that. And then the GLP medications are really they're phenomenal because we have targets in our brain, in our GI system, our stomach, our liver, our pancreas that support these medications. And so patients are able to utilize these in combination with the lifestyle factors and really start to see not just that these are suppressing their appetite or making them less hungry or anything like that, but they're actually working to reduce insulin resistance so that all of the stuff people have been trying to do, they've been trying to eat healthy, they've been trying to move, they've been trying not to give in to the cravings, these medications are supportive in them making those changes.
Wow. Yes, definitely. Everyone has seen the commercials for Ozempic, Wegovy, Rybelsus, and I think there's a Mounjaro's not in Canada yet, but I think my patients are still asking me about this, and they're asking about
Mhm.
whether one medication might be better than the other. What are your thoughts, at least for the same class of medications? What are your thoughts about
Mhm.
whether one medication might be more effective than the other, or better tolerated?
Yeah, so Ozempic, Wegovy, Rybelsus, comparing those 3?
Yeah, and I think Mounjaro you mentioned is another one, and I think there's a
Yes.
fourth one.
Yes. So Zepbound is FDA approved in the US for the treatment of obesity. So as you mentioned, the Ozempic, Wegovy, Rybelsus, those are all semaglutide products. So those are all basically the same ingredient with slight variations. The Ozempic is officially approved for the treatment of type 2 diabetes, where Wegovy is approved for the treatment of medical weight loss. It's also approved for at least in the States, for cardiovascular risk reduction in patients who have a history of prior cardiovascular disease, such as heart attack or stroke. And then Rybelsus is approved for the treatment of diabetes. Now, when we look at Ozempic versus Wegovy, generally they're going to be pretty similar in terms of efficacy, in terms of how much weight someone would lose. Although because Wegovy was the one that was studied for that, we have better information. The Wegovy dosage actually goes slightly higher too. So Ozempic caps out at 2 milligrams, where Wegovy goes up to 2.4 milligrams. So you simply have more medication, and so you can see more effect from it. So we see in studies that after about a year on that medication, patients on average lose about 15.5% of their total body weight loss. So it can be a very effective medication. Now, Rybelsus glutide taken orally is broken down in a pretty significant way. So the Rybelsus dosing is actually pretty low to meaningfully impact weight. So there are patients, of course, weight loss in the medication and can be effective from that standpoint. They are actually studying oral semaglutide for the treatment of obesity, and the Rybelsus doses are 3 milligrams, 7 milligrams, 14 milligrams. They were studying it at 25 milligrams and 50 milligrams for the treatment of obesity, so significantly higher doses. And again, just because it's broken down in the stomach. Now, when we compare the semaglutide products to the tirzepatide products, so that is Mounjaro and Zepbound, Mounjaro being FDA approved for the treatment of type 2 diabetes, Zepbound being FDA approved for the treatment of obesity. Interestingly, the medications are quite literally the exact same. If you look at them side by side, they're in the same injection mechanism. The dosages are the exact same. And in the studies of that medication for the treatment of obesity, if you look at the highest dose of medication, we see about 22% total body weight loss. And in studies where they combined intensive lifestyle modification, so the nutrition piece, the movement piece, the stress management piece, all of that, in combination with medications, patients actually lost 26% of their body weight on average, which is really phenomenal.
Yeah, that's quite significant. And I think even better than I'm probably behind on all these medications, but even better than I remember hearing. I think my next question would be, are there certain people who perhaps should not take these medications or should be a little bit cautious in taking medications, at least these specific classes of medications to help them lose weight?
So, when we think about the GLP medications, most patients will be able to tolerate them pretty well. And they're actually, because they're injectables, they do interact with very few medications. So, most people, in terms of other medication interactions, we're not concerned about. We do know that these medications are not safe in pregnancy or breastfeeding. So, that is the population we're very cognizant of. We do also not recommend them in patients with a personal history of pancreatitis, as well as for patients with a history or family history of medullary thyroid cancer or MEN2 syndrome, which is a genetic type of cancer that can predispose to that. Interestingly, the risk of that is more theoretical than anything. And medullary is one of the least common types of thyroid cancers, depending on the study, making up 1 to 4% of thyroid cancers. Very commonly, I have someone who has a cousin who had thyroid cancer a long time ago, and they're not sure what kind it was. And statistically, it's very unlikely to be medullary thyroid cancer. We do always love to get those records if we can, but it's not always a reason that we would not pursue the medication unless there was a significant family history of that.
So if somebody is, say, not a candidate for various reasons, whether it's financial, whether it's medical, or even just for other reasons, what other
Mhm.
kinds of medications would be considered for weight loss? I have my memories of some of the other classes of medications, but I'd like to hear from your point of view. What other classes of medications are still used? Because I suspect some of these might not be being used anymore.
Yeah, so some of them are definitely outdated, right? There's some medications that have had safety concerns over the years. Interestingly, some of the medications will target things like receptors in the brain that deal with cravings. So the medication bupropion, either in and of itself, used for the treatment of depression, used for the treatment of smoking cessation, it really works to decrease cravings in the brain, can be very effective in the treatment of obesity, especially when people are having a lot of food cravings. Additionally, when we think about this medication, it's often paired with naltrexone to make the medication contrave. That naltrexone helps the bupropion to be more effective. It has a synergistic effect. And so those two medications are often used together. There's a medication called Qsymia, which is a combination of phentermine and topiramate. Phentermine is a sympathomimetic amine, but basically works to a semi-stimulant effect, and there's a decreased hunger with it. Topiramate also decreases hunger. It's an anti-seizure medication used commonly also for migraines and anxiety. And that medication could also decrease hunger through a different mechanism. So those medications are partnered together officially, and Qsymia is sometimes used either together or separately, also off-label. I also prescribe metformin a lot. We usually think of that for the treatment of type 2 diabetes. There is a modest weight loss that can come from metformin use alone. And so metformin can also be used and can be effective for reducing insulin resistance and thereby reducing weight.
So I think there was one medication that I was particularly interested in, and I haven't heard much about. I've heard a little bit about metformin, and I have multiple questions floating through my head. I know this is a little bit. I'd sent you some questions, and this is a little bit off script. But in terms of orlistat, is that
Mhm.
still being used, or I don't hear much about it. What happened to orlistat?
Yes, yeah. So it's still around. It's funny I didn't even mention it because I very rarely use that medication. Orlistat works by blocking lipase, so it blocks the digestion of fat and therefore blocking the absorption of fat. So the idea was based on the low fat diet, that having less dietary fat would be good for us, and that by reducing dietary fat we would lose weight. And in some ways that can be true, but it's a very nasty medication when it blocks the absorption of fat. Any fat that we eat, even healthy fats, unsaturated fats that come from nuts and seeds and fruits or vegetables like avocados and olives and fish, for example, those will not be digested and so can have a lot of side effects like greasy stools, loose stools, greasy flatulence, oily stains in the underwear. So I do not recommend it as a medication for my patients. I will say, interestingly, every once in a while, someone who's having very severe constipation issues with GLP medications, so the semaglutide products, Ozempic, Wegovy, can create constipation. Sometimes we can do a low dose of over-the-counter orlistat. It's available over the counter in the States, at least as Ally. That can be helpful in lubing things up to reduce constipation. But beyond that, I don't see much of a role for it. It's a pretty nasty medication.
Yes, I remember hearing a little bit about it when it first came out, probably when I was in residency, and I don't think a lot of people tolerated it very well. But I think that's a very interesting use to combine it with, say, Ozempic if somebody's having constipation. When would you combine, or do you often combine multiple classes of medications, or do you prefer to do one medication at a time and then add medications? Is this something that's done or something that's like a little bit of taboo?
Yeah, so super fascinating question. I think one of the things that's really challenging is that when we look at the insurance companies approving weight loss treatment, they will often only approve one medication at a time. And so when we're thinking about officially combining treatments, that can be really challenging because the insurance company may say, you don't need Wegovy, for example, because you're already taking Orlistat. And so you can't have two prescriptions commonly. There's no reason safety wise that you couldn't have two prescriptions for those medications, but we sometimes run into limitations from that standpoint. Now, that being said, when we look at bupropion, for example, when it's combined with naltrexone and is branded as Contrave, it is technically a treatment for obesity. When you take bupropion just by itself, bupropion medication is used for depression. It's used sometimes for anxiety. It's used for, other mental health conditions like ADHD. And so we can use it like they're taking it wink for their depression. And so someone maybe, let's say they're taking a GLP, we could also have them on bupropion for their wink depression. We could have them on metformin for their insulin resistance. We could have these other things that are on board. We just have to be careful with it because sometimes we would run into issues about getting multiple medications approved. But I do actually very commonly layer on medications. And when we look at bariatric surgery, for example, which is a whole other conversation, we could have a whole topic and podcast about, but that's 8 medications in one. When we look at the role of bariatric surgery and how that affects our body, there's a lot of different mechanisms that are involved. And so we think about how can we replicate that from a medical weight loss perspective. It really makes sense to layer on different approaches to support patients.
That is so fascinating. And I have my thoughts about treating any kind of medical condition with from multiple mechanisms of action. Like we look at heart failure, and I think now they have 6 or 7 medications that we're using for chronic heart failure.
Mhm.
Even diastolic heart failure. When I was in residency, they controlled the high blood pressure. Now they have 3 or 4 medications that they're
Right.
using. So I think the concept of using multiple medications to help somebody manage their weight is very wise, probably more efficacious. And I suspect that, like, our bodies are not in silos. Oftentimes, when people are struggling with their weight, there are other underlying conditions, whether it is, say, depression or anxiety, that could be contributing to that. So I think it's probably much wiser and brilliant to use multiple medications to manage that condition. But that is a whole nother topic, and definitely bariatric surgery. That's another topic I really want to talk to you about. So I'm going to have you
Mhm.
back so that we can
Yes.
have a deeper dive into these topics. 2 more questions. I think the next question that people would be curious about or would want to know, are there any books or any resources that people should look at if they're interested in managing their weight in say, a natural way or like a more sustainable way? Any online resources that you think people should look at, or any books that you think people should consider purchasing?
Yes, absolutely. So I will shamelessly say my own podcast, the Conquer Your Weight podcast. One of the things I really like to address, there are episodes where we talk about medications, talk about things like physiology, but really what we're addressing in the podcast is some of the behavioral things. Thinking about when you're on vacation, when it's a holiday, when you're at a work party, when someone else comments about your body size or your weight, how are you handling these things? Because a lot of times, those are the factors that we can understand the nutrition, we can have a certain desire for ourselves, but when life gets in the way, those are the things that throw us off of our routine. And so supporting ourselves through that really, really important. And so the Conquer Your Weight podcast is a great resource for that. Lots of books, though, I devour books when it comes to this subject and making sure that my patients feel really adequately supported. Not officially a weight loss book, but maybe my favorite book ever is Atomic Habits by James Clear. That is a book that talks about looking at how do we support patients in their health, in their habits, whether that's starting new habits, whether that's ending old habits. What are the things that we can do in order to start changing our habits? And so that is a phenomenal resource for anyone, but especially in the weight loss journey, I find it really helpful. There's a book I love called The Hunger Habit. And in The Hunger Habit, we look at how are we eating? Why are we eating? A lot of times, when we look at our emotional relationship with food, people will find that they are eating in response to stimuli beyond just hunger. And so, paying attention to this sort of emotional hunger, seeing what are the reasons that this starts coming up, and then really starting to take steps towards changing it. There is a 21-day program that's part of that that pays attention to then how can you start to make these changes in a way that you're eating for reasons that are hunger and not eating in response to emotional stimulus. My last favorite book is a book called How to Lose Weight for the Last Time, that is written by a life coach and physician, Dr. Katrina Ubel. And she goes through certainly some of the physiology, but really goes through some of that coaching component as well. So I really love to recommend those resources for my patients. So this was so much fun. I'm really glad I got to share this message with your audience.
Thank you so much, Dr. Stonbach, for graciously helping me out and answering all my questions despite technical difficulties. For the guests who would like to learn more about you, or even guests who live in your area that are interested in getting more help with managing their weight, where can people find you? What is your website? What is your podcast? We will make sure to put all the links in our description box. But if you could tell us a little bit more about where people can find you.
Yes, absolutely. It is my mission to be providing evidence-based medicine and a supportive environment just throughout everywhere. So you can find me at my website at www.sarahstombaughnmd.com. My podcast is Conquer Your Weight, and then I'm on TikTok, Instagram, Facebook, YouTube channel, launching any day now. So trying to provide a lot of resources to really be able to support patients. We also have a new online course called the GLP Guide. So for patients who have been prescribed GLP medications like Ozempic, Wegovy, Zepbound, Mounjaro, and feel like they haven't gotten great support, have a lot of questions, this is a resource. It's an online library, on-demand videos to answer all the most frequently asked questions about nutrition, about managing side effects. What do you do when you're traveling with your medications? What do you do before surgery? What do you do when someone comments on your body? We have about 55 videos right now, but the best part about it is I tell patients, or not patients, but people who are in the course, if you come across a question and we do not have an answer for it, we will create an answer and make a video just for you. So it's an ever-growing library because we want to make sure that people really feel supported in their weight loss journey.
Wow, wow. Thank you so much as a fellow physician for everything that you do for your patients, for your passion, for all the resources you provide for people. I definitely need to have another conversation with you. I have too many questions, and I'm sure our audience has so many questions about managing their weight. Definitely they should go check out your YouTube channel. As soon as it launches, we will be there cheering you on and telling everyone, even if it's a podcast, we'll tell everyone, please go follow Dr. Stonbach, and we will put a link to all your websites below. But thank you so much.
Yes, thank you for having me.